I'm Kristel Fortune. I'm one of the medical officers at Rahima ED, and I will be going through the approach to chest pain with you guys today. So, where we have to define chest pain, it's basically a general term for any dull aching pain in the thorax. Problem with that is if you think back to anatomy, there's many important structures underlying the area that is highlighted for where chest pain can occur. Where do we start? How do we diagnose? How do we treat? What is going to cause a patient to die right in front of you? Absolutely anything in the body can cause chest pain, whether it's a true chest pain versus a referred chest pain, absolutely anything can cause. So important is to have an approach. When we look at an approach for chest pain, it is important to differentiate the causes between life-threatening causes versus non-life-threatening causes. Because if you do miss a life-threatening cause of chest pain, the patient will end up in a grave. An easy way to remember the life-threatening causes of chest pain is the 4-2-1 rule. So you can have 4 heart-related causes for the 4 chambers of the heart. These are your acute coronary syndromes, your aortic dissections, your pericarditis, myocarditis, and your pericardial effusions versus cardiac tamponades. You can have 2 lung-related causes, which is usually your pulmonary embolisms and your pneumothorax, and then you can have 1 esophageal-related cause, which is your esophageal perforation. This is a nice approach to a chest pain in order to make sure that you don't miss any of the life-threatening causes. So I know it's not displaying very well, but we are going to break it down. Whenever a patient presents with a chest pain complaint, you need to do a primary survey on the patient. During your primary survey, you need to evaluate your patient's airway, breathing, circulation, disability, and environment. Based on your primary survey, you need to determine whether your patient is stable or unstable. If your patient is unstable, you need to stabilize your patient first by supporting wherever you found the problem on your primary survey. Usually in life-threatening causes of chest pain, you actually have to fix the cause of the chest pain before you can actually stabilize your patient. So during your primary survey, you also need to look at obvious signs of life-threatening causes of chest pain. If your patient is stable, you will move on to a focus history and physical examination plus an ECG. It is important that your focus history and physical examination should not delay your ECG. You need a prompt ECG to make a diagnosis. During this process of getting your focus history and physical examination, you will do acute management for these patients, which include obtaining IV access, placing the patient on cardiac monitoring, as well as getting a BP and O2 reading, and then you only provide supplemental oxygen if needed. Once you have your ECG, you need to assess whether there's any signs of ACS. ACS will, if it is a STEMI, present with a localized ST elevations or a new left bundle branch block, which meets the Scarbosa criteria, but that is part 2 of the talk, which we'll be covering next week. If there's no signs of ACS on your ECG, you move on to assess whether there's any of the other life-threatening causes of chest pain. You do this by using your ECG as well as your H's and P's, your history and physical examination, actually. First up, we have a cardiac tamponade. A cardiac tamponade occurs when there's buildup of air, blood, or fluid within the pericardial sac, causing compression of the heart. It is important to differentiate between a pericardial effusion and a cardiac tamponade. They are not interchangeable terms, and they are also not a disease progression of moving from the one to the other. A pericardial effusion is a slow collection of fluid. It requires a large amount of fluid to actually cause symptoms, and it's usually infectious or inflammatory in nature. These patients will present with chest pain, shortness of breath, compression of near structures, but they do tend to be more stable. While a cardiac tamponade is usually caused by chest trauma, rupture of an aorta, or rupture of the ventricular wall following an MI. This is a rapid collection of fluid, and any amount of fluid can cause symptoms. These patients are usually more unstable, and if you are lucky, they do present with a Beck's triad. Beck's triad is when there is low blood pressure because of the decreased cardiac output. You have distension of jugular veins, which is caused by the decrease in venous return to the heart, and you also have muffled heart sounds, which is because the fluid around the heart is not a good conductor of the actual heart sounds. But as I said, do not rely only on Beck's triad to make the diagnosis of a cardiac tamponade. Management of a cardiac tamponade is a medical emergency. It needs prompt action and prompt aggressive action, actually. The first thing you will do is an echo in a patient. This is just a video showing what an echo will look like in a cardiac tamponade. So they are doing a 4-chamber view in this patient. What I like about this video is that it actually shows you how the heart will usually look and in what plane of view you are looking at when you're looking with the transducer. So they're flipping it for us. So remember, atriums at the bottom, ventricles at the top. You can see the massive cardiac tamponade causing decreased cardiac output. You can also see that the right ventricle is completely collapsing. This video is at 1/3 of the normal speed. So just to illustrate how it would look in slow motion, it's just now showing you the actual heart. And then this part of the video is just in full speed again. Yeah. So this is what you should see when you do a 4-chamber view of a patient of cardiac tamponade. So when you do an ECG on the patient, they usually present with low QRS complexes as well as electrical alternance. The electrical alternance is caused by the heart swinging within the fluid. So you'll have a large QRS complex when the heart is close to the chest wall, and then you have a small QRS complex when the heart is away from the chest wall again. You will also usually have a sinus tachycardia, as these patients are usually quite unstable. Please do not wait for a chest x-ray to make your diagnosis. These findings are usually more your pericardial effusions, but patients tend to have a cardiomegaly. They tend to have a water bottle shaped heart. There can be pericardial calcifications, but this is once again when it's a pericardial effusion because of clotted blood within the pericardial sac, or it can be something like TB causing inflammatory changes within the pericardium, causing a pericardial effusion. There might be, if it is a true cardiac tamponade, there might be evidence of chest wall trauma, but please do not rely on your chest x-ray to make the diagnosis of a cardiac tamponade. Management of a cardiac tamponade: if this patient is unstable, like most of them are, urgent action is needed. You need to do a needle pericardiocentesis. You have one of two options. You can either do it echo-guided, which is the gold standard, or if there is no sonar available, you can do subxiphoid percutaneous drainage using the anatomical landmarks, but this is obviously a lot more risky. After doing the needle pericardiocentesis, the patient does need definitive management, which is provided by surgery, by either doing a pericardial window in the patient or by doing a thoracotomy. If your patient is stable, you have more time to get surgery involved for a more definitive management. You do not need to do a needle pericardiocentesis in them. Next up, we have an aortic dissection.
With aortic dissections, there can be traumatic and non-traumatic aortic dissections. The traumatic aortic injuries usually are the patients that die before they get to hospital, so they die on scene or die very soon within their arrival to the facility.
You get two types of aortic dissection, type A and type B. Type A is when it is within the first 10 centimeters of the aorta. These patients are the more unstable ones, as there's many structures that it knocks out when it's in the first 10 centimeters. These are also the patients that present with the aortic root dissections. Type B is anywhere further along the aorta from the first 10 centimeters to the bifurcation. When it is a type A, these patients can present with an MI, they can present with focal neurological deficits due to subclavians being knocked out, they can present with a new cardiac murmur. If it is a type B, they usually present with more asymmetrical pulses, but most of them complain of a tearing pain in the chest radiating to the back. On history, you'll most likely find your risk factors for the aortic dissection. You'll feel like patients that are hypertensive, patients with connective tissue diseases, and your dyslipidemic patients are more at risk for having aortic dissections.
Patients with acute aortic dissection have pretty standard cardiovascular risk factors, like diabetes, having a family history of AAA or aortic disease, genetic diseases like Marfan's or Turner's, vasculitis or inflammatory conditions like HIV, syphilis, smoking, substances like crack, cocaine, tick, so our very typical methamphetamines like we have in South Africa, but anything that can cause atherosclerosis. In particular, for aortic dissections, if the patient has had previous aortic or cardiac instrumentation or surgery.
You can also have no risk factors, but still have an aortic dissection. This video is just showing an aortic root dissection with a dissection flap. It's going to start moving now. There you can see the aortic root in the left lower corner with the dissecting flap moving through. So when you do a chest x-ray on a patient with a suspected aortic dissection, these patients will usually, if it is type A, present with a widened mediastinum. They might also have an abnormal aortic contour. They might have an aortic knuckle double calcium sign, but it needs to be more than 5 millimeters to be significant. Might present with a pleural effusion, usually on the left side more than the right, due to the course that the aorta takes. Late signs may be tracheal shift or left apical cap due to the pressure effect of the blood accumulation. But what is important to remember is in 11 to 16% of patients, they might have a normal chest x-ray. When you do an ECG on these patients, you usually will find non-specific changes. You might have left ventricular hypertrophy from a chronic hypertension, any STEMI changes due to decreased supply to the coronaries. That's usually in your type A when it knocks basically at the root, when it knocks out your coronary arteries. And these patients might also present with electrical alternates secondary to a pericardial effusion because of the bleeding that's captured within the pericardial sac. So gold standard for diagnosing aortic dissection would be a CT scan. So this is just a CT scan showing the aorta coming through now. There we go. Showing the dissecting flap in the aorta. This is quite a large defect that the patient has. This is contrasted study showing you nicely where exactly the dissection is with the dissecting flap. So your management of an aortic dissection is you have your emergent priorities would be to control the BP, to control bleeding, and to fluid resuscitate this patient. These can be achieved by providing oxygen if needed. You also need to have wide bore IV access. Invasive monitoring in this patient would be ideal, especially if you can have an A-line monitoring. You need to activate the massive transfusion protocol especially if this patient needs to go to theatre. You need to correct any coagulopathy in this patient. You need to control the heart rate and the BP. This is usually done by having IV beta blockers combined with a vasodilator. You will aim for a heart rate of 60 to 80, as well as a BP of 100 to 120 systolic. Next would be our pulmonary embolism. So pulmonary embolism, on the history, patient would present with a sudden onset chest pain, which is usually associated with a dyspnea, hypoxia, hemoptysis, and coughing.
There are multiple risk factors for PE. One of the easiest ways to remember them
is the pneumonic thrombosis, which stands for trauma or travel, hypercoagulable state, or hormone replacement therapy, IV drug usage, being older, malignancies, birth control, obesity or obstetrics, so patients that are pregnant. Please just remember that you can still get a PE, and you're specifically at highest risk within the first 6 weeks postpartum. Any surgery, especially if the surgery causes immobilization, and then basically any sickness can be a risk factor, especially if you have your lumbar failures, acid, stuff like factor VIII Leiden. Your lupus can also cause it, antiphospholipid syndrome, but as it can also be something chronic like COPD or nephrotic syndrome. You need to risk stratify your patients to determine if they are at low risk, high risk, moderate risk for PEs. Or you can use the revised Geneva score, but on the Helen protocols, we actually use the Perth and the Wells score.
So bedside assessments for working up a PE include ECG and cardiac POCUS is probably the most important. Don't forget to do a DVT assessment via point-of-care ultrasound, and it's important to pretty much look at the whole leg, not just limited compression ultrasound. Look at lung POCUS because maybe it'll help you with the differential, and don't forget to do a chest x-ray.
You can also do an ABG on this patient, which will show a reduced partial O2, and that is in keeping with the size of the PE. So the larger the PE, the lower your PaO2 will be. You will do an ECG. ECG, most of the time, will only show you a sinus tachycardia. In very rare cases, cause the S1Q3, T3, or other ECG finding would be your non-specific ST changes or T-wave inversions, especially in the anterior lead, which is indicative of right ventricular strain caused by the pulmonary embolus, or you can also have P pulmonale and a right bundle branch block.
So probably the most important clinical exam for us to do is a cardiac point-of-care ultrasound at the bedside. So this video demonstrates a large right ventricle. And if you look at the size of the RV as compared to the size of the LV on the left, it's really big, it's dilated, and it shouldn't be. You can see that the interventricular septum is flattened, and it can actually be sometimes so severe that you get significant bulging of the interventricular septum into the left ventricle. There'll be a dilated plethoric IVC, and this video is showing McConnell's sign. So you get akinesia of the mid-free wall of the right ventricle with sparing of the apex. So you can almost imagine a little guy jumping up and down on the apex as if he's jumping on a trampoline. Don't forget to do a DVT assessment too. Chest x-rays are invariably negative in patients with a pulmonary embolus, but it's still important as part of your differential. There might be very subtle changes, and if you're lucky, you might see a wedge-shaped infarct, like is shown in this x-ray that's showing the Hampton hump. Advanced imaging very well might depend on what you have access to and your level of skill. If you don't have great poker skills, you might need a senior to help you with a formal echo and a formal DVT sonar. If you're working in a facility that has access to CT scan, doing a CT pulmonary angiography is great because it can also delineate other pathologies as well in the chest, but shows the pulmonary embolus beautifully and can tell you about the size and distribution of the pulmonary embolus, as well as having a CT sign of RV to LV ratio as well. And it's described quite nicely in CT. Doing ventilation perfusion, scintigraphy scans, less common these days, but also depends on where you work. And pulmonary angiography, although in the old days was very much the gold standard, it's very invasive, and in the ED we don't have access to this. This is an image from a CTPA showing a non-contrasted scan on the left and then a post-contrast scan on the right. Both of them you can easily identify the filling defect in the right pulmonary artery. What about D-dimers? They're probably one of the most over-requested and misinterpreted tests. Everybody seems to want to do one when they're suspecting a PE. So D-dimers are naturally released when clot is broken down. So when there's increased clotting, there's increased clot breakdown, which will cause an elevated D-dimer. There are many different causes for an elevated D-dimer. This means that it's a very non-specific test. The D-dimer must be interpreted with caution, and you must interpret it in conjunction with the likelihood of there being a PE. So look at your risk stratification. A negative D-dimer can be helpful in a low risk for PE patient.
A negative D-dimer rules out a PE, but a positive D-dimer does not rule in a PE. You have to then further investigate.
Don't use D-dimers in patients who've got a high risk for PE because they have an unacceptably high false negative. Rather use other investigations.
Remember that there is certain criteria that does change your D-dimer. These are your age-related, that you have to adjust your D-dimer. You see there is a formula. So basically, if they take your age, if it's more than 50, you times it by 10. Then you also need to remember to adjust your D-dimer for pregnancy. So there is trimester adjusted. You have your first trimester, second trimester, and third trimester. And with each trimester, because of the changes in the body, the D-dimer does go higher. So how you would manage your pulmonary embolus is you will, if your patient is hemodynamically unstable, this is usually what that you pick up in your primary survey. You will fix your ABCDs. So A, you might need to intubate the patient if there is cardiopulmonary collapse, or if your patient is in cardiac arrest. If your patient is not breathing adequately enough, you need to support the breathing. This can be provided by high flow O2 because that will also assist with pulmonary vasodilation, and you need to ventilate to optimize your VQ mismatch, and sometimes you do need to hyperventilate to clear the CO2, so that will all be seen on your ABG. Your ABG will guide your ventilatory support. You need invasive monitoring in this patient preferably. You need to optimize your fluid management so that you can support your right ventricular function, which is taking strain, and you need to provide inotropic support with either adrenaline or noradrenaline. What you do need to be careful of, however, is that you do not overload this patient, because remember, the heart is already struggling with the pulmonary embolus, and fluid overload is not going to help the situation. So based on the severity of your pulmonary embolus, you need to decide how you're going to manage it. If it is a massive PE, patients are usually hemodynamically unstable. You need to thrombolize this patient. So thrombolization usually occurs with RTPA or alteplase. Ideally, this patient needs an embolectomy, but obviously in our facilities, it is not always possible. If you have a patient with a submassive pulmonary embolism, this is usually when the patient is hemodynamically stable, but there is evidence of right ventricular dysfunction. You need to risk versus benefit, whether you need to thrombolize based on what their risk for bleeding is. But these patients with the submassive usually get half those thrombolysis with low molecular weight heparin. Your non-massive PEs, these are your hemodynamically stable patients with a normal right ventricular function. These patients are usually treated with anticoagulation, so low molecular weight heparin plus minus an anticoagulant. Usually the anticoagulant is when they are discharged, but they do get started with in the wards. Obviously, this is not what we start in ED. We do the low molecular weight heparin. Then next would be your tension pneumothorax. These patients tend to present hemodynamically unstable with a sudden onset chest pain. They are dyspneic, they have unequal breath sounds, they have tracheal deviation, and they can have pulsus paradoxus. This is a clinical diagnosis. Please do not wait for special investigations to make the diagnosis. It needs a clinical urgent diagnosis and urgent medical intervention.
Point of care lung ultrasound is really important for looking for pneumothoraces, so the absence of lung sliding, and the presence of a barcode or stratosphere sign if you put the sonar in M mode. But those are not diagnostic of a pneumothorax, they're just highly suggestive. If you see a lung point sign, that is diagnostic of a pneumothorax.
When you do a chest x-ray, which preferably you should not be doing in a tension pneumo, these are more your pneumothoraxes, you will see basically a complete collapse of your lung with no lung markings running through, as you can see on the left side here. ECG is non-specific in a patient with a pneumothorax. They can just have a sinus tachycardia, but it's usually non-specific. Management of a tension pneumothorax, you can do a needle versus a finger thoracostomy. Just remember, fourth intercostal space, metaxillary line. We do not go second intercostal space anymore, and we are moving away more from needle thoracostomy, doing a finger thoracostomy, as that is already the start of your ICD, which is your definitive management in a tension pneumo. After you've performed your finger thoracostomy, you need to place an intercostal drain for these patients.
Once you've inserted your intercostal drain, you need to clinically assess the efficacy of the drain. And then you do need to do some imaging, so do a post-ICD insertion chest x-ray and a POCUS just to confirm the position of the intercostal drain.
Next up is your esophageal rupture. From the history, the patient will usually present with a chest pain that started after vomiting or retching. You can have two types, which is a spontaneous. These are usually caused by Burhoff syndrome or deceleration injuries. Or you can have penetrating trauma to the neck, stab neck, chest, gunshot wounds. They can all cause esophageal ruptures. These patients typically present with subcutaneous emphysema, and it can be quite widespread. They can also present with retrosternal or pleuritic chest pain if they've had the esophageal rupture for more than usually 24 hours. These patients can present with fever, sepsis. They also tend to have dysphagia, adenophagia, hoarseness, and if it was trauma to the neck, they can have cervical tenderness. Special investigations that you'll do is when you do a plain chest x-ray, It is quite difficult to visualize, but you can see that there is free air running just next to the mediastinum. But when you do a contrast esophageogram, you can actually nicely see the esophageal rupture. Other special investigations that you would do, ECG is not usually diagnostic. CT you only use when you cannot diagnose the esophageal rupture by any other means. What you will see on CT is basically what you see on the esophageogram, contrast esophageogram with x-rays. And this would be a wall discontinuity. You can have contrast extravasation. You can have a pneumomediastinum with esophageal thickening if it's been long-standing, and you can have mediastinal fluid collection. Management of esophageal rupture, your aim is to repair within the first 12 hours of rupture. So when the patient presents, you need to stabilize if the patient is unstable on your ABCDEs, and then you need to call the surgeons urgently because they need to perform a primary repair and drain the fluid. If it's been more than 12 hours since the rupture, a primary closure is discouraged due to the infective nature of esophageal ruptures. They need to do a generous drainage, drain out all the fluid, especially if it has formed an empyema. You also need to do a diversion of the esophagus, and you need to do aggressive antibiotic treatment in these patients. These patients, if it's been more than 12 hours, tend to not do great. So urgent surgical referral, urgently get your surgeon on board is important for these patients.
Now that Kristel's dealt with most of the life-threatening causes of chest pain, apart from ACS that she'll chat about later, she's going to go through the non-life-threatening causes of chest pain. Causes of chest pain that are not imminently or not immediately life-threatening.
Then you can also have a myocarditis. Myocarditis is it's usually a viral infection, but it can also be caused by your inflammatory conditions like your lupus, polymyositis. You can have giant cell arthritis as well as drug-associated like your IV drug uses. Nice little breakdown. It is when there's inflammation of the heart muscle. You can also have a pancarditis, which is pericarditis, endocarditis, and a myocarditis, and it's also known as, it's mostly caused by your acute rheumatic fevers, and it's when all the layers of the heart is involved. These patients tend to be quite sick when they do appear, so it can actually mimic your life-threatening causes of chest pain.
Referred pain from the abdomen is another cause of chest pain. So patients who've got cholecystitis, cholelithiasis, pancreatic or GIT issues also very well might be experiencing chest pain.
Gastroesophageal reflux disease is something very, very, very overdiagnosed, but it can cause significant chest pain. And it can actually make the patient feel like they are having an MI. Important with the gastroesophageal reflux diseases, this patient tend to have retrosternal chest pain. It tends to be worse after eating, after lying down, or after exertion. Patient might have dysphagia. Patient might report that there is heartburn, might report that there is regurgitation of the food. And what is important is that these patients do actually have quite significant relief immediately when you give Pantelog. So what you can do is you give them some Pantelog, see if their symptoms does improve, but you do need to do an ECG to make sure that it is not a life-threatening cause like an MI. So pneumonia is usually due to inflammation of the lung alveoli, which causes white cells to accumulation within the alveoli. These patients can be either hypoxic with the increased work of breathing or they can be stable with no increased work of breathing and just chest pain. Pleuritic chest pain is when there's inflammation of the pleura. It's usually infectious or inflammatory in nature.
Pleurisy, or pleuritic chest pain, it's a symptom. It's not a diagnosis, and there's lots of causes. For example, pleural effusions, empyema, pneumonia, pulmonary emboli, masses, multiple reasons. Musculoskeletal and connective tissue conditions can result in chest pain. Musculoskeletal are actually fairly common. There are traumatic and non-traumatic causes that can result in chest pain. So fractures, muscular contusions, sprains, strains, they're important causes of non-cardiac chest pain. Non-traumatic causes of chest pain are very often inflammatory or infectious. We don't want to be making the diagnosis of costochondritis in the emergency department. Costochondritis is dangerously overdiagnosed and results in us missing important differential diagnoses.
Hey, Kristel. Thanks for your talk. I think it was a good, concise, rapid fire on all the big things in chest pain that we shouldn't miss. Obviously, we guys work in emergency medicine, so we love ultrasound. So most of these things you can pick up very quickly with ultrasound if you know what you're doing. Just to add, it might be a bit more nuanced. For PEs, you can look at something that we call the 60-60 sign. So you look at tricuspid regurg and flow through your pulmonary artery, which can also work.
Thank you, Kristel. That was an excellent presentation. I agree with what Isaac said, and he said a lot of the stuff that I wanted to say. So I just wanted to make a comment on the last couple of slides that you showed. While I think it's a good idea to think about the 5 life-threatening or so-called life-threatening causes of chest pain, and the ones that you rightfully named, I would probably not call the others, like the myocarditis and the pericarditis, non-life-threatening. So I think just to clarify that for the more junior staff, those can potentially be life-threatening, especially the complications of those disorders can be life-threatening. So patients with myocarditis or pericarditis can certainly have arrhythmias that result in sudden cardiac arrest and things like that. So just to keep that in mind. But the other 5 are immediately life-threatening. So if you don't correct them now, the patient will die.